Hi again, I'm Vic Lyons. Really delighted to be with you all this afternoon and really fantastic to see a wide range of people here with us today. Student nurses, different applied health professionals, nurses of all different branches. So really exciting that you were able to join us today. Today we're going to be talking about dementia in people with learning disabilities. I hope you'll find this session informative. I hope it'll be helpful. We will have space for questions at the end, so do feel free to put questions in the chat box. Jane and I are both also on Twitter, so if you want to catch either of us on Twitter, if there's conversations that you think you might like to ask us afterwards, please do feel free to message us afterwards as well, and get some, have any questions you might have. We're really more than happy to help. So if I can have the next slide, please. I know this is part of the summer school, so you'll have heard lots about what Admiral Nurses are, but just in case people have just joined this session, it would be worth just giving you a quick bit of information in case you don't already know this. Admiral Nurses are specialist dementia nurses. They're nurses, so it's a registered nurse who might come from any different branch, but a nurse who's specialised in dementia and has some specialist knowledge of supporting people with dementia. The work is around supporting family carers, people living with dementia, and it's through the whole trajectory of someone's diagnosis. So some of the work might be around helping somebody get a diagnosis, around supporting somebody with understanding the signs and symptoms, especially, you'll hear later from Jane, but especially in the learning disabilities angle, there's a lot of work which is pre-diagnosis. And then once someone's had that diagnosis, supporting them, looking after people when things get complex, when things get hard, and really working with people throughout the trajectory. The other side of the role, split role, is about education, leadership, development, supporting other staff and colleagues. And in essence, wherever we have an Admiral nurse working, the kind of goal is that that Admiral nurse, we will invest lots in the practice development of that Admiral nurse, but that they will then upskill other people around them. Next slide, please. Again, you probably have heard this information, but just if you haven't, we have over 300 Admiral nurses working across the UK. That number changes all the time. It goes up and it goes down as people join and people leave. And later on, you'll be hearing from Jane. And Jane, as Caroline said earlier, is a specialist nurse working with people with learning disability, and she's the first one. Hope for more, but she's the first one. So we're really excited that Jane's with us. The Admiral nurses, as I said earlier, support people through the tough times, through the difficult times, through the challenging times. They work in a variety of settings. Some are in community mental health teams. Some are in different settings, in acute hospitals, in community teams, in care homes, in a wide range of settings, and Jane's in LD. Next slide, please. I think this one is just talking about the model in general. So this, again, I spoke earlier about the way that we work and about it being around complexity, and all people, wherever they've got that diagnosis, will need advice, they'll need support, they'll need information given to them. Some people might need a little bit more in terms of the support that they get. They might need, somebody to work with them who's got that more of information, that more knowledge, somebody who can work in a more collaborative way, perhaps across services. And sometimes when things get difficult, people need an Admiral nurse, and that's the model that we're working with. It's around that complexity. But ideally, we want people to step up and step down to this, because some people at the point of diagnosis, it might be that's where actually they need the most support. Other people, it might be later on in the journey where they need the support. So it's a fluid model. It goes up and down dependent on the needs of the people you're working with. So whilst this is a linear sort of static model, there is definitely that flow up and down between them. Next slide, please. So we're currently working through our strategy, this is Dementia UK strategy that we developed, which lasts from 2020 to 2025. And as part of this strategy, we wanted to develop specialisms amongst our Admiral nurses and have nurses working in areas where, you know, in a diverse range of people and in areas where perhaps there wasn't already Admiral nurses. So it was one of the strategic aims that we set as a charity. So getting Jane in post and having Jane and hopefully more Janes working in the way that she is doing now was definitely part of our strategic aims. Also, we wanted to work with other people in underserved communities, be that people in prisons or people from a range of backgrounds and communities. But just it was worth mentioning that it is clearly part of our strategic aims to develop more services to reach people with a learning disability. Next slide, please. I think I'm going to hand over to Jane now for a bit.
Well, thanks for that, Vic. Hi, everybody. So I just wanted to give you a brief kind of overview of MCINER, so the charity organisation that I currently sit with. So MCINER provides support for people with learning disabilities, and approximately 1,200, and that's a mixture of children, young people and adults. Across England and Wales, and within their services we have residential services, we have shared lives, supported living, lifelong learning centres. So it's a real varied mix of the people that we support. So next slide, please. Okay, so just a little bit of history around the Dementia Project. So the Dementia Project was developed approximately 4 years ago, and a lot of work was done between Dementia UK and MCINER, and both of those charities had a shared vision, and that shared vision was to continue the Dementia Project and host the UK's first learning disability Admiral Nurse, to ensure that really the Dementia Project carried on and the support they gave would progress. And within that Dementia Project, as you can see there, we had lots of resources developed, which are all free to access on our website. The project also won 3 national awards, and obviously led to funded projects, one of which was mine. So next slide, please. So what do I do? So dementia can be really difficult to diagnose in people with a learning disability due to their pre-existing cognitive and functional impairments and the way that dementia symptoms may present in early stages. So often families and health and social care workers are not aware of the increased risk of people with a learning disability developing dementia at a younger age than the general population. And this can often lead to a delay in the diagnosis process, and the chance of appropriate interventions and support can be missed early on. So the role is divided, or my role is divided into developing best practice models, engaging in cross-team consultancy and developing and delivering training to teams. So, and a large part of my role is actually raising awareness of dementia in people with learning disabilities. Some of my project aims, as you can see on the screen, are to support people pre-post dementia diagnosis, to make sure they receive a timely diagnosis and make sure that the support that they have is truly person-centered and that the environments that they're living in are tailored to their needs. And also looking at, you know, before any diagnosis, looking at the environment and how we can try and sustain somebody's current living should they go on to develop dementia. So in terms of health inequalities, obviously we try and reduce those inequalities, and also look at things like STOMP, which is stopping the over medication of people with learning disabilities, which is something I look at when I'm actually working with people, providing assessment and emotional practical support for teams, and also advice and guidance to family members. It can be people that other people that the person may live with, and of course the person themselves. So it's quite a varied piece of work. Next slide, please. Okay, so as I mentioned briefly earlier, it is a funded post. So it's a 2-year funded post, and it's hoped that at the end of the 2 years, and it's already kind of being looked at now, that we can secure the post to go further after those 2 years. The project will provide evidence of the impact of such a role as a learning disability Admiral nurse, and it will evidence the positive benefits to people with a learning disability and dementia. The project can also support ongoing research into the effects of dementia and best practice when supporting a timely diagnosis for people with learning disabilities and or autism. I think we have a poll next, I believe. Laura, I don't know if you're over, fab. So I just wanted to have a look. So the poll, well, you're obviously reading it. So what is the average age for someone with a learning disability to develop dementia?
And just to let you know that the poll is anonymous, so don't worry about your answer. And just let me know when you want me to end it, Jane.
Okay.
I'll share the results.
Yeah, let's give it a little bit of time. So we've got 64% people voted. Okay, so I think if we look at end polling now. Okay, so not everybody answered, but actually the majority were correct. So 50 is kind of the average age. I'll go on to explain from a younger standpoint, you know, where we look at when we start looking at baseline screening people for dementia. So thank you for that, Laura. I think we just have to cross that off our page to get back to the PowerPoint. Oh, someone couldn't see the poll, I'm not sure why. We'll have a few more coming up. So yes. So if we can have the next slide, please. So these are facts and figures within MCINER specifically, and we will look at the bigger picture a bit later on. So currently we have 20 people diagnosed that have a formal diagnosis, and we've noticed that the numbers have dropped over the last year, which I think sadly is because we have lost people due to COVID, but also because the opportunity to have an assessment has also reduced significantly during the pandemic. We have 28 people that are suspected to have a diagnosis, and we hold an at-risk register. So anyone over the age of 40 who has Down syndrome, we class as at risk. Currently we have 78, and people at risk over the age of 50 who have a learning disability, 353. So when you think of, you know, overall we support 1,200 people, and a portion of those, I think about a third of those, are children. Actually, those numbers are quite high that are on the screen. And just within my year so far, I have seen quite a significant increase in those people at risk as we have an aging population. So in terms of service I can't speak, put my teeth back in, service implications, obviously that's huge, because this is just MCINER. So when you know, looking at the whole population of people with learning disabilities in the future, it's definitely something we need to consider. So next slide, please. So I just briefly wanted to go over the definition of a learning disability. So it's estimated there's about 1.5 million people in the UK that have a learning disability. And MCINER defines a learning disability as the way a person affects the way a person learns new things in any area of their life, how they understand information, and how they may communicate. So this might mean that they have difficulty understanding new or complex information. They may have difficulty learning new skills, and they may need additional support being independent. But it's just really important to remember that everyone is different. So, and everyone will have different degrees of support. Some people can live very independently with only a couple of hours a week, if that. yeah, so we're all unique, learning disability or not. So next slide, please. So in terms of the bigger picture, so we have reports that have come out, some people may be aware of, known as LEADER, which is the Learning Disability Mortality Review. And this actually has highlighted over the last few years the health inequalities that people experience that have a learning disability. And also that life expectancy is considerably less than the general population. And people are just dying far too soon. And sadly, you know, we heard recently, this is a continuing theme. So as you can see on the screen, we can see that women receive less screening for breast cancer and cervical screening. Adolescents and adults with disabilities are less likely to receive sex education programs. As I mentioned, men with learning disabilities die 13 years sooner, and women 20 years sooner than the general population. I think there's generally a struggle to access mainstream NHS health services. You know, often a few people might have difficulty with reading and writing, and often we get letters and texts from the NHS with appointments, which obviously if somebody's not supported, they can miss appointments. So there's a real combination of things that can have a huge impact on somebody's health, and the inequalities as well that they may experience in their lifetime. So next slide, please. I believe we're over to you, Vic.
Thank you. Sorry, so we've talked a little bit about the kind of facts and figures, and you know, we know that there's 1.5 million people with a learning disability, and we know that 1 in 10 are going to potentially develop dementia. So these numbers are significant. They're large numbers of people that we're talking about. When we think about Down syndrome, which is a condition that we'll talk a little bit more about, we know that the numbers are even higher. So for people with Down syndrome, 1 in 50 people in the kind of 30 to 39 age bracket will potentially have dementia, will have dementia. 1 in 10 as people go into the 40 to 49 bracket, and 1 in 3 in their 50s. So it's large numbers of people that we're talking about. And there is some further challenges around actually getting that diagnosis without even thinking about COVID and the implications of COVID. Can I look at the next slide, please? So why is it that people with Down syndrome are more at risk of developing dementia? It's one of those questions that we get asked quite a lot, and it's actually quite interesting because the main reason that people are at risk, we think, is because of chromosome 21, and the fact that that extra chromosome has, you know, that people with Down syndrome are more likely to have, carries the amyloid gene, which we think again has a role in Alzheimer's disease. So various bits where, you know, that we're not entirely sure. And when you look at brain scans, it's quite interesting, because if you look at brain scans of people with Down syndrome, you will see significant changes in a number of people. If they're over 40, or in fact almost all of them, will have changes in their brain to show that there has been the increased amyloid. However, not all of them will go on to develop dementia or will show signs and symptoms of dementia. So this is why there's a little bit of extra research needed really to be done around that to help exactly understand some of the risks. But that is research that is being done. It's ongoing as we speak. So we're still waiting to see more about that. In terms of treatment options that are available, again, you know, we know, anybody who's on this webinar today knows that there's no cure for Alzheimer's disease. There's various drugs that you can use. Donepezil, for example, is a drug that we often use in dementia with mainstream, and yet there's no studies that have been done to show that that works for people with Down syndrome. So, you know, it's often a drug that isn't prescribed, or clinicians aren't sure whether they should or whether it's beneficial. And it can mean that people are excluded from drug treatments that actually might help to delay the decline and to make a difference to the quality of life. And they're not getting them because you know, clinicians don't always know that they can prescribe it. There's also been some really interesting new findings. And those findings actually show, they did a study, and you can find out more information on this, we'll share some links later on, but in a study where people were started on some of the anti-dementia drugs, they found that the lifespan increased and people were living on average for like, you know, nearly 6 years longer once they were on the drug. So it was living for 6 years when they were on the drug and 3 years when they weren't on the drugs. So we do think that by slowing down the decline, giving somebody better health outcomes, you know, keeping somebody independent, living better on their own, actually increases their life expectancy as well. So, you know, really, it should be that we're really looking at using these drugs to support people and help maintain their life. We know within the learning disability world, obviously there's a lot of emphasis on drugs not being given unless they're necessary, and there's been massive campaigns and STOMP that you'll probably be aware of around the, you know, not ensuring people aren't over medicated. So it's always one of those areas where, you know, if you're going to give any drug, you want to be sure that it's going to be beneficial. But you know, it does look like the anti-dementia drugs are useful for people with Down syndrome. Again, statistically, we're talking about around 40,000 people who we know have got Down syndrome in the UK, and who, you know, may have dementia. So again, large numbers of people who might be missing out on, is increasing their life span and also having better health outcomes because of using various drugs that are available. So it definitely is something worth considering and looking at if you're working with somebody who has got Down syndrome, has developed dementia, actually asking that question, is there a treatment option? Can we start them on a drug? Because it might just make the difference between, you know, a significant number of years of that person's life and better health outcomes. Next slide, please. So at this slide, we're going to do a poll again. So I hope everybody can see it this time. So I noticed there were some comments in the chat about people not being able to see it. But this one is about diagnosis. Can you do the poll? Thank you. Just going to leave it a little bit. Seems like it's still actively going up a bit. It's leveling off now. And as somebody is saying they can't see it, I don't know why, because it looks to me as if it should just come up on your screen, but I don't know if that's because of how you've accessing this webinar. I don't know if it works on mobiles, on different tablets, or laptops, I don't know. Certainly on my laptop it looks like it's working, so apologies for that. I know someone just commented that they couldn't see it. So this question is about whether there is a recognised pathway if people, you know, get the same treatment. And it's interesting because there's a bit of a split there, isn't there, you know, between no, there isn't, and I'm not sure whether there is or there isn't, and then a couple who think yes, there is. The honest answer is there isn't. It's one of the things that it can vary so much dependent on who you're supported by, where you sit in the country, what street you live on even, what support's around. If you're linked with an organisation, if the person is linked with an organisation such as MCINER, there's a pathway that they use across MCINER. But if you're living with your mum in street X, you know, you're very much, it's reliant on what the commissioners in the area have commissioned and how it looks. And we know that some people will get their diagnosis made through going through memory services, going through memory clinics. Some will be within learning disabilities. I've heard of people being diagnosed almost because they've got Down syndrome and they start to get a bit confused and a bit muddled, and someone goes, oh, well, it's probably dementia, so let's just put dementia probable, and then suddenly the probable goes and it's just they've got dementia and there's no diagnosis. And in other situations, Jane was telling me of a story recently about somebody who, as part of the diagnostic process, they were asked questions about who's the monarch. You know, these are questions that this person wouldn't have known anyway. So actually, what was the point in asking that question, and how would that, you know, really help you make that diagnosis? Because if you're asking something that somebody really wouldn't have known anyway, they're not, it doesn't tell you anything other than that they don't know the answer to who the monarch is. You know, so it does have to be appropriate. Again, I've heard conversations where people have been trying to do virtual diagnosis, and that really not working at all. And I think there's a big question mark about how well virtual diagnosis is going to work with people with dementia anyway. But you know, it definitely, I think, is not going to work when someone also has an additional learning disability. So thank you. I think there's part B of this poll as well, is that you should have another question, I think. Thank you. So having just heard me saying that, do you think there should be one? That's coming in pretty strong, isn't it? It's interesting, is this, because I can tell you, when I asked this question, I'm going back probably 6 years ago, I was told, well, no, because they should follow the same pathway as everybody else. You know, the pathway that works for Joe Bloggs, who's developing dementia, should be the same as Mary Bloggs. Just because she's got a learning disability, it should be the same pathway, not a special one. And actually, I can kind of see the logic at that time and what that person was saying, you know, about treating everybody, not treating people differently and treating people the same. But actually, it's got to be appropriate. It's got to be, you know, reflective of the different needs that somebody might have, and the different, you know, kind of what somebody might, the skills that somebody might have anyway, and the skills that they might not have. So I'm really glad to see that, and I completely agree with you. There should be a national pathway, and it is something that we're having conversations around developing, so that people, wherever they live, that, you know, get a fair treatment, and, you know, sensible, well thought out pathway is exactly something we're looking at trying to develop. So thank you, everybody. Next slide, please.
I think this is over to me, Vic.
I hadn't realised I would have done this one.
No, that's fine. Okay, thanks, Vic. So, so looking at signs and symptoms of, are they different for people with learning disability? Well, a short answer is no, not really. But what is, so it could be more difficult to detect, and I think especially in the earlier stages as well. So I often find in my particular work, the things that tend to crop up more so are changes in the person's mood, and also changes in the person's behaviour. And when I say that, I don't mean necessarily in a negative way, but, you know, one example I was given, a gentleman that we support who is autistic, and he had very keen interest in a particular area, and the staff team started to notice that actually he was reverting back to an interest that he had sort of 10-15 years ago, which was really unusual for him. And other examples of having a bath but going to sit in the bath with no water in, whereas actually he used to be quite independent, turn the taps on, you know. So it was things like that were changing, that they were thinking, oh, this isn't quite right. It has been quite difficult in COVID, obviously, because of the impact that that's had on people in general. We've had to be very mindful of the changes in routine and how that impacts on some of the people that we're supporting as well. In terms of, I mean, we know, most of us know, dementia isn't all about memory loss. For example, some people can experience personality changes, and as I said, changes in mood, or behaviour can be the most obvious symptoms. So I think the key is looking at somebody's abilities and whether or not they're losing any of those skills. And then we need to start digging a little bit deeper as to why those skill sets are changing. Dementia signs and symptoms usually develop gradually, but sometimes can accelerate rapidly if the person has other health conditions. So, for example, I'm not sure of the statistics, but people with learning disabilities are increased risk of epilepsy. And if you think that people with dementia can later go on and actually, as the structure of the brain is changing, they're more at risk of developing epilepsy, even if they didn't have a learning disability. So there are lots of things that can be going on in the brain, which can obviously change the structure, and that has an impact on how somebody may present. And obviously that increases the risk of developing dementia. For people with learning disabilities, sometimes the dementia symptoms can be overlooked. So the health professional may see the learning disability first and not actually the changes that teams or the person themselves might be reporting on, or family members. And that's known as diagnostic overshadowing. So, and that can be quite a difficult thing to overcome, but I'll talk a bit later on about some of the tools that we use within our organisation that really help us to evidence those subtle changes to clinicians, and hopefully, or we have found it does help with the diagnosis process. So I think it's important we look at any changes for that person. So, you know, we're looking at the slightest thing. So as I said earlier, it can be, you know, changes in activities of daily living, the way somebody communicates, the way somebody responds to things, even answering to their name, you know, whether they stop turning their head when you call their name. Little things like that can be subtle changes that we might see. And the other thing I wanted to share was the common referrals that I get. And as I mentioned beforehand, that they do tend to be changes in the person's behaviour and mood. So, it tends to be one extreme or the other. So they've either become extremely withdrawn, or they are becoming more active, and, you know, the way they communicate might change. And signs of anxiety increased as well tend to be the referrals that I see come through the most. Next slide, please. So diagnostic overshadowing, and as I said, I mean, this isn't just exclusive to MCINER, and I'm sure anybody who's with us this afternoon that supports adults with a learning disability probably has come across some sort of issue in terms of diagnosis, not necessarily just in dementia, but other health concerns. So, and we do find, as I said, that often the learning disability is seen before, rather than actually exploring the changes. And we do have really good examples of when clinicians have supported community teams, learning disability teams who are experts in the field, are very supportive. You know, you can get speech and language therapists, OTs, learning disability nurses involved, who are able to see the person first, and that's so important, because, you know, like anyone, when they go to the doctors, they're often not well. That's why we go, and they're often not themselves. The same when somebody's in the hospital. So it's good to get that picture of how the person was, or how the person is, you know, when they're fit and healthy. Next slide, please. So in terms of timely diagnosis, so it's dependent on a lot of factors. So obviously the willingness of the GP to assess them, the assessment tools being used, and as we know, there's no one single test for dementia. I see a mixture of people that, if they're supported by staff teams for many, many years, then they've known them and they can kind of follow that process through and give really good examples of how somebody may have been years before. and also looking at baseline screening, which again I'll touch on a bit in a while. So it also depends on how the person responds to an assessment, and whether other tests that can be carried out to rule out any other health conditions that might actually be giving a false impression of dementia symptoms. So often people with learning disabilities that I've supported anyway can be quite resistant to having medical interventions, such as having blood tests done. Even hearing and eye tests can be really, really difficult for some people to take part in. So we have to do a lot of desensitization work for people to try and get those tests done, so we can rule anything else out before going further with seeking a dementia diagnosis. So some of the problems that we find, people having to wait a long time for appointments to come through, which can be particularly difficult. And I think also noisy waiting areas, which can be really disruptive for some people, but trying to think about reasonable adjustments and how they can affect a person and make life a bit easier and make it more likely that that person will go and have a health assessment. And I think we've got a poll on that in a little bit, so I won't go into that too much. But so in terms of referrals, so it's always best to try and refer to a specialist. So NICE pathways, they recommend dementia diagnosis and assessment, and they advise that referring people with learning disabilities who are suspected to have dementia, they should be referred to a psychiatrist that has an expertise in people with learning disabilities, or treating mental health problems in people with learning disabilities, because that can really help the process. The availability of future assessments. So for a person with a learning disability, having regular assessments may be the best way to assess changes that they're experiencing. And within MCINER, we use a health calendar, which I will go on to discuss in a minute. But they can really help with documenting those real subtle changes, and having the baseline screening really is effective for that. So I believe we have next slide, please. I think we have a video coming up. I just wanted to give you a quick history before we play the video, if I may. So this is Alison and Rachel. Some of you may have seen this video. It is on our website. So Alison and Rachel were supported by MCINER, and they were childhood friends. And in their 20s, they decided to get their own place together. They worked together in a local bakery, and they did all the sorts of things that best friends would do. So they shared a love of ABBA, and they loved going to musicals together. So Alison, who is the lady in the red jumper in the picture, was a very independent lady. She only needed 3 hours support a week from MCINER, so she was able to live, a healthy life and very independent. But it was Rachel noticed a change in Alison, and the changes she noticed was that Alison had got up for work at 8 a.m. like she did every morning to go to the bakery, but she'd started to get up on a Saturday at 8 a.m. and Alison never worked Saturdays. So it was Rachel that reported this to support staff, who then were able to begin monitoring for any other signs. And at the age of 46, Alison received a diagnosis of dementia. And I think it really highlights the emotional impact of dementia on people with learning disabilities and their friendships, and the importance of us listening to friends and family. So, support staff play an amazing role, but we really need to listen to the people that are sharing their lives with that person. So I think we are going to play the video now, if that's okay.
You going to introduce Alison?
Sometimes I call her Pussycat for short. Sugar Jam.
We're only going to be talking about your friendship with Alison. You used to work together and things like that. Yeah? What's on your mind? She's having a nap. Do you want to explain about how long have you known Alison?
For quite a long time.
Quite a long time. And you live together? So you've been flatmates and workmates as well, haven't you?
Alison and Rachel have lived together for coming up to 28 years. Before that, they likely went to school together. They had an instant connection between them. You knew their friendship was genuine. As best friends are, they were just very close. They did everything together. Despite being very different people, they just fit together. Alison and Rachel were always in each other's personal space. There's no boundaries. They would hug each other, they would kiss each other. Rachel refers to Alison as Pussycat and will shorten that to Pussy. She also has always done this thing where she touches Alison's nose, and Alison used to move her nose up and down like a bunny rabbit. And Rachel will say she loves that. She loves to stroke Alison's face and will give her kisses, and is a very affectionate person, and for Alison it's extremely valuable because she doesn't have that much intimacy in her life anymore, so that to come from Rachel must be extremely soothing, I think, for Alison to still get that closeness and the touch. It's just lovely to see them together as a pair, as they are. In the beginning, before we got Alison's diagnosis, there was quite a few changes that as a staff team we didn't pick up on until Rachel told us about them. So she was the one that witnessed the behaviour, she was the one that then reported it to staff, and without that information I don't know whether we would have got the diagnosis as quick as we did. Rachel can often change Alison just by entering the room. If Alison's having a particularly bad day, and all of a sudden Rachel comes along, Alison looks around and, I recognise that voice, where is she? That's very comforting, and really important that they stay together for that reason.
What would it mean to you if Alison moved out?
No.
No.
No one to live.
Yeah. Would be quite upsetting for you, wouldn't it?
Yes, it would.
Do you think it would be upsetting for Alison?
Yes.
Yeah. She would miss you, wouldn't she?
No, I only want to live there. I wish it would go away. I wish I could walk again as well. Pussy, I love you. That's it.
It is going to be Jane next, but just while she's waiting, I just wanted to say thank you for persevering with the video. I know it was difficult when we thought we couldn't find it, but I'm really glad we did, because it's such an important video, because I think it really portrays the impact that a diagnosis can have, and actually what's really unique about the Alison and Rachel story is that it was her friend who was the person who noticed the first signs and the symptoms, and actually alerted people to the fact that she was concerned about what was happening for her friend. And we'll talk a little bit more later on about circles of support, but I think it's a beautiful video and really illustrates really well the significance of a friendship and how that diagnosis.
Yeah, absolutely, incredibly powerful. So thank you for that. So
I thought a break afterwards was a good idea, so you can go grab your emotions again and get ready to go on. Yeah. Jane, are you there?
So I am, yes. Hi, thanks, Fit. Yeah, I like that, and I'm hoping to do a follow-up very soon with Rachel, so that'd be good. So I wanted to have a chat about changes in behaviour, and as I said, this is one of the most what's the word, the most regular referral reasons that I have come through, changes in a person's behaviour. But it's important to remember that these changes might not be linked with dementia and could be for lots of other reasons. Obviously, you can see on the slide there changes in the person's environment. So things like a new person moving in with them, somebody moving out, has the environment been recently redecorated? You know, I've heard people who are autistic might respond to the smell of the paint, you know, if they're particularly sensitive with smell. So there are lots of little things that can make those changes happen, and it's not always dementia. Somebody experiencing a sense of loss, and that can mean somebody who's actually, you know, a new staff member coming into the team, or an old member of staff leaving the team. And sadly, over the years that I've practiced, you know, staff come and go, and it's not always explained to that person that the member of staff is leaving to go to a new job. They just leave and never come back, you know. And if it's somebody that they particularly had a good relationship with, then that can have a huge impact on the way somebody may present, and they may struggle putting those feelings of frustration or anger into words. And we may see that being, you know, they're trying to communicate in other ways their feelings, and that can be when the changes of behavior come in. Poor lighting within an environment. So if somebody starts bumping into objects, or seems to find it difficult negotiating around their environment, then it's kind of thinking about, you know, what else could be going on for this person, you know, eye screening, hearing, etc. But we'll talk about that in a little bit. And also the temperature, you know, something as simple as a temperature can really you know, change the way somebody may present. So could cause agitation, as I've put there, amongst other things. So next slide, please. So underlying health conditions. So remember, these are all some of these are quite common for people with learning disabilities, but it's trying to think of actually, you know, what else could be causing these changes in the person, which doesn't necessarily mean that there is a dementia present. So poor eyesight. So the person might not be able to communicate changes in eyesight. So asking staff to monitor small changes is really helpful. So for instance, you know, if a person likes drawing, and you notice that they're struggling to actually pick up certain colored pencils, or just any pencil, could be a really obvious sign that they're struggling in terms of eyesight. So that's a really important thing to get checked out. Hearing loss. So again, communication is huge for somebody with communication. I think one of the biggest problems throughout the pandemic is people have really struggled with is, you know, the staff supporting them having to wear masks, and actually the difficulty that can cause, coupled with hearing loss. You know, I was surprised at how much I actually lip read, and I think my hearing is pretty good. So these are all things that we need to consider. People with learning disabilities you know, most commonly do follow an unhealthy diet. Not everybody, obviously, many of the general population do as well. But this can lead to vitamin deficiencies, and that can also cause presentations which could be mistaken for dementia, such as a lack of vitamin B, which could cause an added confusion for somebody. So again, that's kind of where the blood tests come in really important as well. Unidentified constipation. So that somebody could present as being unsettled, a change in mood, grumpy, you know, withdrawn, understandably, if there's constipation there. Effects of medication, and also considering polypharmacy. So if somebody's on lots of different types of medication, it's, you know, really important to get those reviewed regularly. Some medications may longer be required, but, you know, they need to be reviewed by the GP. And, you know, and obviously side effects can cause a change in somebody's mood. It can affect the way a person sleeps or doesn't sleep. So again, these are all things that we need to think about. Obviously, for anyone, poor sleep. So, you know, reduced sleep can cause confusion during the daytime. It can, you know, somebody may present as reluctant to engage in activities, and just reduced sort of mood, bit more withdrawn, like the rest of us, really. You know, if we don't get enough sleep. Early menopause, again, more common in ladies with Down syndrome. So changes in hormones, you know, I was going to say we all know, not all of us do, but the changes, you know, in hormones during the menopause can be huge, the way somebody presents. So again, that's something really worth considering, having explored. Cardiac abnormalities, so more common again in people with Down syndrome, and that can, for instance, it might increase somebody's tiredness, so they might be more sleepy. So again, something to check out. And hypothyroidism, again, more common in people with Down syndrome, and that can cause weight gain and also tiredness as well. So these are all things that we need to sort of be thinking about when we're considering dementia. So if I can have the next slide, please. Now, I think Vic touched on this briefly earlier, but we had a lady that had a dementia assessment over the phone last year with her GP, and the member of staff, support staff, was with her. So I think, you know, initially just that kind of telephone call was really tricky, really difficult for her to understand what was going on. But some of the questions that were being used weren't really appropriate for her. So obviously Vic mentioned earlier about using the term monarch. So she didn't understand what a monarch was. They also asked if she could recall somewhere that she'd been in the last 3 weeks. Well, this was right at the beginning of the pandemic when everything shut down. So nobody had been anywhere within the last 3 weeks, really. Her day services have been shut. So again, the support member of staff supporting her was able to highlight this to the GP. There are tools out there, you know, NICE do have guidance around what kind of tools should be used, more specifically for people with learning disabilities, and we try and encourage clinicians to use those, and again, we have very good examples of where they are used and reasonable adjustments are made and things are brilliant, but we also have the flip side of that, unfortunately. Next slide, please. So how do we support this within MCINER? So we record changes in a person on a daily basis, actually 3 times a day. And we use something called the Anticipatory care calendar. And this compares changes that we notice. So a person will have a baseline health assessment first, and then these very small changes can be noted on a daily basis. But we'll talk about that a bit more in a moment. Working alongside the person, so you're picking up those changes and experiencing. So remember, I think for staff, it can be really difficult because how often do we get to reflect on our work on a daily basis? But often, you know, that reflection can make you think a little bit more about some of the subtle changes that we're seeing. So talking to everybody who supports and knows that person, and that includes family members, staff within the service, other services that the person might access, so whether that be day services or work if a person holds down a job, and getting their input as well of any changes that might be noticed with that person. Then speaking to the GP and really, you know, explaining and highlighting that you've collected all this information. In addition to that, having the health calendar I mentioned and all the evidence that that goes with that can be really, really helpful for clinicians. And it's also one thing we've noticed that quite a few people are offered a dementia screening questionnaire, which, you know, I call it the DISQUID, I know, and that was a specific tool just to screen whether there was any signs potentially that the person needed to go on for a full dementia assessment. And what we found is that actually we aren't given copies of that for the person's records. And so a person might have had that screening done many years ago, and then it's not reviewed on a regular basis. So and that can, you know, that in itself could pick up really subtle changes. So we're trying to encourage within MCINER that staff ask for screening to be done on a regular basis, predominantly for people with Down syndrome, to coincide with their annual health checks, just to try and have that regularly monitored. And as I mentioned earlier, there are tools out there that can be used for people that are specifically aimed at people that have a learning disability. And I guess being persistent. So if a GP needs more evidence, it's our job to provide that evidence, you know, as much as we can to support that diagnosis. Now, I think, right, no, not yet. So next slide, please. Thought we had another poll, but I think it's after this one. Okay, so I mentioned it a minute ago. So the anticipatory care calendar. So this tool is owned by NHS Innovation Agency, which is located in the northwest of England. It was developed in response to a gentleman that died. His name was Robert, and he died at age 33 of testicular cancer because the screening was missed. The subtle changes were kind of missed by people. So the NHS said they were committed to improving outcomes for people with learning disabilities, and therefore this calendar was created. So just before we look at the calendar in a little bit more detail, I think we've got a poll coming up, please, Laura. Okay, so you can see there, what age should a baseline screen happen? Or what age? That doesn't make sense, that question, does it?
Does it mean stage? That could have been a copy and paste error. I wonder who did that.
It's probably me. It's probably me.
Oh, no, it's good.
Okay, so yeah, should be completed. So, I mean, age-wise, we would be looking at somebody with Down syndrome. We recommend, or it's recommended that from the age of 30 should kind of be the age group when we're looking at actually starting doing that. And yes, it is when a person's well. So when the person's, you know, functioning with no other issue. So it's kind of as you or I, how we are day to day. So thank you. Just close that one down. Brilliant. So yeah, so it's recommended that we do that, and it is because it's so important that we get it when people are well. That kind of makes it helps the comparison definitely later on. Do we have another poll, or is that a bit later, Laura? Ah, there you go. Fabulous. So how often should that baseline screening be reviewed? So yeah, I totally agree. I personally think it should be as part of the annual health check. Doesn't always happen though. So yeah, it does depend on her age, Laura. Okay, so there's quite a lot of response coming in. So yes, I think it should be part of an annual health check. It's recommended that every 2 years and every 5 years as part of an ongoing health check. So when changes are noticed, it should be every 2 years, and thereafter every 5 years as part of the annual health check, which is what you guys have, majority of you guys have put. So if we can go on to the next slide, please. Okay, so Obviously, the baseline assessment I was talking about then in terms of screening is different to the one that we use within MCINER, but with the anticipatory care calendar within MCINER, we encourage, or it's mandatory, that everybody has a baseline assessment. And usually, so if a person comes in new to the service, we would probably recommend that that assessment is completed approximately 6 months after the person's moved in. So obviously time to settle in, time to get to know the person. Then we would complete, and this information would be what's normal for the person, and it's best completed by somebody that knows the person really, really well. Obviously, if family members are connected to that person, then we would involve them. Anyone else, it's an information gathering exercise, so it can be people that they share their home with, all these subtle little things about what makes a person tick go into that baseline health assessment. And once it's completed, we ask for it never to be archived, and it stays with that person. So the document belongs to the person, it doesn't belong to MCINER. So if they ever move to a different support service, that would go with them, and that is the evidence of what the person used to be. Next slide, please. So health monitoring. So it's important we review the baseline health assessment for changes. So any changes are then recorded on this particular document. You can see there, which is the monitoring health assessment. And this is so we can clearly evidence to professionals what the person used to be like and the changes that we're seeing now. And this information is shared with teams, and we encourage people to take this to key appointments that are relevant, obviously, to those changes that we're seeing. Next slide, please. I always think this looks a bit scary, this one, but so the calendar works on a traffic light system. So it covers the sheet that you see in front of you covers 31 days in the month, and it would be completed 3 times a day, and that would be initialed by the member of staff at the end of each shift for the changes that they've noticed. So you can actually change it into a graph, so it records trends and any patterns that you might see. It covers 12 areas of health recording, so it covers things like pain, changes in behaviour, bowels, sleeping, urine, so changes in urine, seizure activity if the person has epilepsy, eating and drinking. So that would look at whether they're taking food and fluid okay, any trouble with dysphagia, with coughing, choking, changes in skin, mobility, health observations, and there are places for other symptoms that can be completed. And then next slide, please. So for each, the good thing about this tool is for each area, so if you were ticking or initialing, sorry, green, 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 then we know that that's all good for the person. But actually, if we then start creeping into amber or into red, it actually tells you what to do. So it tells the staff member, okay, we can't leave this, we need to action something, which is, you know, really, really valuable. And we do get some really positive feedback around that. Go to the next slide, please. Thank you. So the significant communication sheet. So this is kind of, so anything that flags up on amber or red has to be acted upon. So what we have to document on here is what was the concern, what did we do about it? If there was a health professional involved or a specialist, what did they do about it? And then what was the outcome for the person? So the outcome part, you know, might not be completed till further down the line. So say somebody had a urine infection, you reported that to the GP, you got antibiotics. So we wouldn't actually document the outcome until the antibiotics course was finished. Was it successful, you know, or did we need to go back for some more? And that's kind of how we would evidence things with that, which has worked really, really well, and it's available to anyone. And I believe there's links to it on at the end of the PowerPoint if anyone's interested in finding out a bit more about that as well. And I believe we have another poll now, I hope. Yes, I'm fibbing. Okay, so yeah, so there you go. Which of these are classed as being a reasonable adjustment under the Mental Health Act? Oh, sorry, dogs are barking. So just give you a couple of seconds to have a Okay, so we've got 70% people voted there. And yeah. Okay, should we end that now? I think we've got, yeah, thank you. So yeah, again, the majority are right. Actually, all of those are considered a reasonable adjustment and really should be considered or asked for. Things like the double appointment time, I've actually had GPs say, thank you so much for, you know, making sure that you've booked that, because it gives them more time to speak to the person. And there's less pressure on that clinician as well from a time perspective. So yeah, they're definitely things worth considering. So if I can have the next slide, please. Okay, if we can go on to the next slide, that'd be great. Sorry.
It's not moving forward, Caroline.
Go back again in a second.
Thank you. Brilliant, thanks. So this slide I put together, so it's really things for professionals to think about. Thank you. Thank you, Caroline.
Working now.
Yeah, thank you. So it's things to think about from a professional point of view. So always assume capacity, which is in line with the Mental Capacity Act. So, you know, consider, does a capacity assessment need to be considered? You know, do you have concerns about that? But again, it shouldn't be a barrier to them receiving an assessment. And consider whether or not you'd be supporting this person in their best interest in terms of going further with that assessment process. Communication, to find out what their preferred method of communication is. And if they're supported by somebody, you know, then this is information that you can ask that person, or if the person sat in front of you in surgery, then obviously ask them. Listen to the person and those that support them on a regular basis. So, you know, often as clinicians, we have a snapshot of somebody who comes into a clinic, whereas some of the people that are supported, you know, their staff members or family members have known them for many, many years, and therefore are often a better place to provide that extra information. When thinking about baseline assessments, just consider, have they been assessed in the past? And does the care provider use a baseline assessment tool? So as in the one I've just talked about, part of my role would be to encourage staff to take that baseline assessment as a comparison for the GP with evidence, or whatever clinician is actually assessing the person. It can be really helpful for them. Consider when they last had an annual health check. And also, I think whether this was done over the phone or in person, especially with the pandemic, because, you know, you might be relying on other people in the home to do things like blood pressure checks, etc. So it's just worth considering that, or are they due one? So could it be something else in terms of health? And just really to reinforce the reasonable adjustments. and just try to facilitate that when we can, as often as we can. Next slide, please. Circles of support. So Vic, I think it's back to you now.
That's right, thank you. So we've talked a little bit about things to consider when you're assessing somebody, and really in terms of circles of support. Do you want to do next slide, Caroline, just so people can see the list as well? It's absolutely vital that the whole circle of support is considered. And I guess circles of support is a term that we've all got more familiar with recently because of COVID, and we were allowed to form bubbles with those in their circles of support. But it's actually a term that we've used for quite a long time in learning disabilities, and it's around recognising the family, the friends, the flatmates, the housemates, the people who are around the person, their peers, colleagues they work with, of course paid staff as well who might be involved in supporting somebody, and anybody across the person's community, so that they are assessed in line of what all of those other people think as well. And we've all got circles of support. Every single one of us has got various circles of support. And we would hope that were any of us to get a diagnosis, that people would ask questions of our significant others and take that information on board and work with. And as we heard earlier on in the first video that we shared, it's actually really important that those family members and friends are spoken to, because they might just be the person who's identifying the first signs that something's different for their loved one. So we are going to share another video. So the next video, I'm just going to give you a little bit of information around this video while we're getting it uploaded onto the screen for you. So this is a video from James and Angela. It's another one of those videos that I feel should come with a health warning. Get the tissues ready. It's another one it's emotional. So James and Angela both have got learning disabilities. Specifically, they've got Down syndrome. They've actually been known to MCINER for around 40 years, so for a very long time, and married for over 20 years. In 2017, Angela was diagnosed with dementia, and obviously her husband, James, became her carer. Life story work is something that I'm going to talk to you a little bit more in a bit, but we know in dementia care and also learning disabilities that life story work is really important. And it certainly was important for MCINER. And Angela specifically asked, when they were doing a piece of life story work with her, to make a film about their wedding day. So that's what we're going to see. Is some of that. What's actually really interesting is to tell you is that what happens in the video, the staff team did not know was going to happen. It was a complete surprise to them when they turned up on the day to talk to Angela and James about their wedding, to see what Angela and James had planned. So I hope, while I've been doing my preamble there, that the video is ready to go. Fingers crossed.
My name's Angela Berryman. I'm James Berryman as well.
My name's Elisa Abbott. I'm a support worker for MCINER. I support Angela and James in their everyday living on. We don't spend that much time supporting them. We're only here for maybe half an hour in the morning, an hour in the evening, and then half an hour. But apart from that, they are perfect couple, really. We support them wherever or whatever they need to do. We'll support them to going to work, going to the dentist, doctors, if they want us to. They both do sometimes turn around and say, no, we are fine. We have to respect them. They're a married couple. They know their own mind.
Can you tell me about when you met?
I met James as he grew up. Yeah, I did well. I was in the 38.
Lovely, thank you. And how long ago?
A long time ago now. Yes.
And can you tell me about your wedding day?
Well, on the Fifth Shepherd ordered the flowers for my Aunt Jessica's wedding. Fifth Shepherd. He sent down the flowers for me for our wedding day.
Fantastic. And is there anything on your wedding day? Was there anything that you had at your wedding day? Did you have nice cards? Or?
Yeah, we did. Yeah.
Cards and presents.
Can you tell me about your wedding dress, Angela?
Me and my sister chose a wedding gown and a veil and white shoes.
You look beautiful.
Thank you.
And what about your suit, James?
I did that a long time ago now. So that I better put it on today, special day.
Hello, James.
Hiya.
I think people with learning disabilities should really be allowed to do life as much as they can. If they find love, it's amazing where it comes from. And why can't they get married? Why can't they live by themselves? If they can, they just need a little bit of help and support.
How long have you been married?
A long time now.
Long time now.
17 years now.
Fantastic. And do you remember how you felt when you first met?
I saw him long time ago.
Yeah, I'm the same, yeah?
Yes.
And we were at the post tour at the sister's car.
Yes.
1 year down.
He did.
Was that when you proposed?
Yeah, I did, yeah.
And how did you feel, Angela, when James proposed?
I was happy for him.
Hey, don't cry. It's okay. It's okay.
I was a bit nervous that day.
Yeah, you did, okay?
Them as a married couple, they are so in love and so as a couple. I've never heard them argue with maybe the 6 months I've been with them.
So, can you tell me what kind of things you like to do together?
We do cook. We do it, but in turns we do. Do we, Anne?
Yes.
This is my turn to not tonight, are we, Anne?
No.
What are you going to do this evening?
And we're going out for a meal. Me, my brother and his wife Mary. They celebrated my birthday.
Fantastic. When was your birthday?
October the 7th, gone.
That was Friday, just gone.
When I was like younger, you know what I mean, it was like, no, it was a thing you don't talk about, no, you're not allowed to get married. But I don't see why not. I really don't. And it proves that Angela and James are so happy and in love.
So we'll share our rings together.
Fantastic.
For me, all the girls from the group home, Jackie was there, Dave was there, Andrew Michelle was there, and they get married some day, our wedding day.
What about, did you have a cake?
There's a big one.
We got
We got it on the photo album.
And we went to the holiday, didn't we?
Yeah, we did. It's Spain, Ibiza. We Debbie McKenna.
Was that for your honeymoon?
Yeah, that was.
Fantastic.
And we went to Paris. I got we went to that. We did, didn't we?
Yeah, we did.
We were there after, didn't we?
Yeah.
Naughty and nice.
Yeah.
James, so can you tell me how you feel about Angela?
There's white hair. They look beautiful. Aren't you?
Yeah.
You are beautiful.
Thank you.
And Angela, how do you feel about James?
Definitely a nice person. I care about him a lot.
Thank you, everybody. I can see some comments coming up in the chat box about that video, and I think it's beautiful. I've seen it a few times now, and every time I see it, I end up grinning and smiling and feeling all warm and fuzzy. It's just beautiful. They're relationship goals right there, isn't it? So I think the thing with that video that is really important as well is that life story continues. You know, your life, just because you get a diagnosis of dementia doesn't mean that your life's over. You know, your history is there and it's important, and if it's captured, you create something really beautiful that people can use again and again as they go forward together in their lives. So that's obviously an example of a way to capture someone's life story, you know, to kind of create that video and the video that Andrew and James wanted to create. But, you know, life story can be done in any way. It could be kind of an album, it could be pictures on people's wall, you know, it could be recordings, videos, tape recorders, all sorts of different things. Tape recording, how old am I? I don't know if anybody does record tapes anymore, but, you know, the different methods are available to create the life story. I think the important thing is that it doesn't remain static, because people are still living, people are still experiencing things, and things change. You know, so somebody who's really significant at one point might not be, or their relationship might change, or somebody might suddenly hate fish when they've always liked fish. So, you know, you might have to change that. So it needs to be a continual process that keeps with somebody. It needs to be a live document. There's no point doing a life story and sitting it in a drawer somewhere. It needs to be something that's accessible, that people can look at and enjoy and engage with. So that we just always need to talk a little bit about it, because most people really enjoy talking about themselves and their experiences, and be guided by the person themselves. If they don't want to do a life story and feature a part of their life, don't feature it. You know, it's up to them to decide what's significant and which bits they want to put in there. Next slide, please. The next slides really are about kind of the planning for the future, and we all have to plan for the future. You know, and life story is a good place to start thinking about that if you haven't done it before with somebody. And actually, you know, all of us are aging, we're all growing older. So having plans in place that sort of you know, outline how you want your later life to look like, where you want to be. Would James and Angela want to stay together no matter what, or would care be needed at some point? You know, kind of detailing those plans. And obviously, you know, we know that sometimes things change and people don't get the plans they want in life, but, you know, at least if they're there and they're documented as this is my future plans, these are the things that I would like to achieve and realise, then you know, it really should be a document that people have the chance to develop whilst they've got capacity, and that they maintain and are able to use it. Next slide, please. So we've got some information here about sharing best practice, and essentially there's various links that are on here as well. Oh, Jane, sorry, I think this was your slide, wasn't it?
No, that's okay. You're doing a fabulous job. No. Yeah, no, it was just really to just share some of the resources that we've got on MCINER's website, which a lot were the legacy from the initial Dementia Project. So yeah, and they are accessible to anybody that wants to use them. So yeah, just thought I'd share them really. So think the next one's yours, Vic.
Next slide. Again, these are some resources that we've put together, and these will be all available for you later on, so you don't have to kind of frantically grab these, but we just thought they might be useful for you to have these links and some various different bits of information, so that if you do want to do some further reading after this session, you've got some pointers there. Next slide, please. So the what next really is we need more Janes. We have one Jane. Jane is amazing. She's, you know, truly is amazing. And you've heard all the work that Jane's doing at MCINER. What she hasn't told you today is she's also been shortlisted for various awards because she is that fantastic. But we need more people like Jane. If we think about those 1.5 million people out there with learning disability, you know, Jane just simply cannot reach them all and support them all, no matter how hard she tries. So we are keen to develop more nurses into the role that Jane's in, and if people have got ideas about how to do that, feel free to get in touch with me and let me know. And sometimes you know, it might be a conversation with the Commissioner about developing a service and looking at the kind of diagnostic pathway or the adult social service pathway and sort of going, well, actually there's a gap here. It might be a nurse who's working in learning disabilities, supporting people with dementia, who thinks actually what Jane's talked about today could potentially be me in my role with a little bit of shaping. So do get in touch with us. We'd love to hear from you, and I'm more than happy to have those conversations. So you'll find my details like when we send out the information later, but you can also find me on Twitter at Vic Lyons. So do feel free to reach out either way to grab me. Next slide, please. It's just, we always put this slide up because sometimes when we're doing sessions like this, there's things that come up that you think, actually, do you know what, I need some support, I need somebody to talk to, I need, this has raised a question or an emotion, or, you know, really I just need some guidance. So our Admiral Nurse Dementia Helpline is there as a resource for people to phone up, get some advice. And we do speak to people who are professionals themselves. So if you're working with somebody who, you know, has got learning disability and has got dementia, you can also phone the helpline to get some advice and support. Jane can't take direct referrals herself unless it's people who are within MCINER, but if people do phone our helpline, a lot of the nurses on there are pretty good at helping, even if they've not got specific experience in working with learning disabilities, they have got that excellent knowledge when it comes to supporting people with dementia. So do feel free to phone our helpline and get some information from there if you need to.